talk of the 2021-2022 mini med school seminars. So my name is Julia DiPieri, and I'm a second-year medical student at the UBC Vancouver campus. And again, Dr. Gare is our supervisor, and hopefully she'll be able to come in and say a few words and just welcome everyone. But I think we'll just get started for the sake of time today. So our talk today is going to be about a variety of different tests that your doctor or healthcare provider may order. So by no means will it be an exhaustive or all-encompassing lecture, because otherwise we'd be here for hours. But hopefully it might give you some more insight into why we are ordering certain tests, what exactly we're testing, and what we might try to be gaining from the results. And as well, you're welcome to have your microphone, or we'd like you to have your microphone off for the duration. But if you'd like to have some questions during the intermission or towards the end, feel free to turn on your mic at that time or put them in the chat as well. And in terms of video recording, we will be recording all of our series. So if you do have to leave at some point, feel free to do so. And we'll provide the link where the talks will be posted at the end. And even if you have your video on, it won't show up in the recording, so don't worry about that. So as is customary with all of our talks, we're going to begin with a territorial acknowledgement. So I'd like to begin by acknowledging that I am personally joining you from the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I also recognize that many of you are joining us from the territory of the Wungan peoples, on whose traditional territory the University of Victoria stands, and the Songhees, Esquimalt, and Wasanich peoples, whose historical relationships with the land continue to this day. And as we're probably used to right now, we are medical students, so these talks don't constitute or substitute for medical advice. And so many of the tests I will mention can be ordered for a multitude of reasons. And I won't necessarily bring up all of those reasons, but I will try to mention the ones that are most common and most relevant. So please always consult with your healthcare provider if you have any questions about your specific health situation, because they will obviously know best in terms of your own situation. I won't necessarily be mentioning many of the actual numerical values as well, because a lot of the values are typically standardized depending on age and sex, and therefore it wouldn't be of much value for me to go into that, but I will mention it for a few things. And I know a lot of you have signed up for our future talks, which is absolutely amazing. But if you haven't had a chance to look at them, this is what we are going to be talking about. So yeah, Drew is going to be talking about genetic testing next week, same time on Sunday. And Nicole will be talking about diabetes the following Sunday after that. And then in the new year, I'll also be talking more about medications and how they work, and as well about drug interactions. Nicole will be talking about stress and how what the effects of that are on your body and how to potentially manage that a little bit better. And Drew will also talk about some diets and supplements as well. So we hope to see you at all of those talks if you can. So this is a general overview of what we will be talking about today. So I'll be talking about a variety of common blood tests that can be ordered, and I'll do my best to describe to you what we're testing for, what the results might potentially mean, and in some cases how frequently they should be ordered, as some of these can be used for more screening rather than for diagnostic purposes. So there's a few tests within each of these categories, but generally we'll be looking at some more routine blood tests, such as a complete blood count, electrolytes, also looking at lipids and glucose and kidney function. And then I'll also be looking at some other tests that may be ordered in more specific situations or in the acute care setting, such as for the heart, the liver, some hormones, as well as blood clotting ability or coagulation. So I'd like to start off by seeing where everyone's coming from in terms of prior knowledge. So I've got a few quiz questions. and they are anonymous, so the results won't show up linked to you specifically. But I'd like to see what people think. So you should see this on the front of your screen. So which of the following tests assess kidney function, and select all that may apply. So we've got fasting plasma glucose, creatinine, a complete blood count, and glomerular filtration rate. Okay, we'll give it a few more seconds here. All right, so it looks like we're starting up. We have a good start. So the correct answers are creatinine and glomerular filtration rate, which most people answered correctly. Complete blood count can definitely be used in coordination with things that we do assess for kidney function, and fasting plasma glucose can also be very important in the setting of diabetes. But in terms of directly assessing kidney function, it is typically going to be creatinine and glomerular filtration rate, and we'll definitely go over those a little bit more in detail later on. So I've got another one here. So which electrolyte imbalance can most commonly lead to a life-threatening emergency? So we've got sodium, potassium, chloride, and bicarbonate. I want to see what you think. I'm going to put a few more seconds here. All right. So again, the majority of you did get it right. So all of these electrolytes are very, very important, and definitely if they're way out of whack, they can lead to life-threatening emergencies, but we most commonly are worried about potassium, because even, there we go. Even very small changes in the level of potassium in terms of going too high or too low can really affect the heart, and we'll talk more about that as well. So well done, everyone. We have one more. And so if you walk into the ER and say you have chest pain, which of the following tests do you think will be ordered to rule out a heart attack? So we've got potassium, albumin, troponin, and thyroid stimulating hormone. This is very interesting. We'll give it a few more minutes or a few more seconds. All right. This was very interesting. So this is good. This talk is going to help a lot. So the answer is troponin. I know I may have confused you a little bit in terms of just mentioning that potassium is very important for heart function, and it definitely is. But troponin, as we will go over a bit more in detail, is a marker of heart damage. So you would definitely order a potassium as well, but troponin will definitely be more of the one that we're looking for in terms of a heart attack specifically. Awesome. Thanks everyone for participating in that. Did I close it? Oops, there we go. All right, so let's get started here. So we'll start off by talking about some more of the screening type tests, but they can also be ordered in the acute care setting as well. So we'll talk about a complete blood count to begin. It's a very common and very easy test to order, and it involves looking at the number and proportion of red blood cells, as well as their hemoglobin content, as well as white blood cells and platelets. So some reasons you might order a CBC might include as part of regular blood work at a hospital, anemia, infection, suspicion about bleeding disorders, or malignancies. So there's really a variety of different things that you might order this test for. And by the way, these slides will all be provided as well with the recordings, but you're more than welcome to take notes if you'd like. So when they do take a sample of blood, they will spin it in a centrifuge to isolate the various components. So this is basically what it's going to look like before they spin it, and this is what it'll look like after. So each of these components can be analyzed separately depending on what you're trying to test. So for some things in the plasma that we like to look at are electrolytes, as well as proteins. As you can see, it's majority of it is water, but a lot of these different components are very important for us to analyze. And then in terms of the complete blood count, we're looking at more the formed elements here. So the red blood cells, the platelets, the white blood cells as well. And if any of you have ever had a complete blood count, this is probably what you may have seen or something similar. So at the top here, we've just got the overall count of the white blood cells, the overall red blood cell count, hemoglobin content, which is the red blood cells' ability to carry oxygen. Hematocrit is the proportion of red blood cells, and I'll show kind of what that looks like visually. MCV stands for mean corpuscular volume, and this is the actual volume of the different red blood cells, and this can be very important in the setting of anemia. These other ones here all are very similar to the MCV, so they're not as important, but the platelet count is very important. And then especially in the setting of infection, a differential might be ordered, and so that would mean that they're looking at the specific types of white blood cells, and that can help distinguish the cause of whatever might be going on. So talk a bit more about red blood cells. So we're primarily looking at the absolute number of red blood cells, and then their ability to transport oxygen to the body tissues. And like I was saying, hemoglobin is the protein on red blood cells that is responsible for binding and holding on to that oxygen until they reach the tissues, at which point then they release oxygen and take on carbon dioxide instead. And then hematocrit is the proportion of red blood cells to the other components, and a change in hematocrit can signify different diseases as well. So if there is an issue with the number of the red blood cells or the amount of hemoglobin, this can result in anemia. And so even though anemia is thrown around as a very common term, there are actually several different types of anemia. And like I mentioned, that's where the mean corpuscular volume can come in and can really help us determine what the cause of the anemia might be. So for example, a very common cause of anemia is iron deficiency or blood loss. And so if the hemoglobin is low and then the mean corpuscular volume is quite small, this might point us towards iron deficiency. And another test called ferritin, which I'll talk about a little bit later, would also help us distinguish that. Vitamin B12 deficiency in older age is also quite common and can cause anemia, as well as different bone marrow diseases and cancer as well. And then hemoglobin is also very important to monitor, as it can be an indicator in the setting of anemia of whether a blood transfusion is warranted or not. So if there are too many red blood cells, this can result in a condition called polycythemia. So this is a bit less common, but polycythemia basically means thick blood. So some causes of polycythemia include polycythemia vera, which is a blood disease, or there's also conditions that can cause you to be in a lower oxygen state, and therefore your body tries to compensate for that by increasing the number of red blood cells. So things such as COPD or congestive heart failure, sometimes severe sleep apnea, and also certain tumors can also secrete erythropoietin or EPO, and this can also stimulate red blood cell formation. So like I said, this is kind of a visual of what these different conditions might look like. And as you can see, between male and female, the expected hematocrit can be quite different. But in the case of anemia, you're going to have less red blood cells compared to plasma, whereas with polycythemia, you're going to have way more blood cells compared to plasma here. So we'll talk about white blood cells next. So their main function is to fight off infection and disease. And this test measures the overall number. And if a differential is ordered, we'll also distinguish how many of the different types of white blood cells there are. And if if a certain type of white blood cell is elevated, then this can help distinguish the type of disease that's happening. So the different types of white blood cells include neutrophils. So this is the primary disease fighting one. So that's the one that we'd expect to usually be during a normal time to be a little bit higher than the others. Eosinophils and basophils are typically quite low in the normal setting. So if those are elevated, that might be suggestive of something, as well as monocytes and lymphocytes as well. And then if you've already read ahead on this slide, you'll notice that this is, some of the things like infection and malignancy and inflammation can both cause white blood cells to be too high, but also too low. And so this is where the art of medicine comes in and where the clinical context is extremely important. So for example, white blood cells might be too low in the setting of a very severe infection because the white blood cells may have already been destroyed by the infection. So if the infection is winning, essentially the white blood cells might actually be destroyed and consumed and they won't be there. And the body isn't able to keep up with that loss. Autoimmune processes can also destroy white blood cells or the bone marrow that makes them. And certain cancers or malignancies that affect the bone marrow as well, and certain medications as well can cause white blood cells to be too low. In the settings of white blood cells being too high, this is typically what we think of with infection. So the body is mounting that immune response that we would expect, and that would cause the white blood cells to be higher. Inflammation can also cause that type of process because that infection and inflammation typically go together. And certain types of cancers or malignancies can also stimulate white blood cell formation because the body is recognizing the cancer cells as these foreign invaders and is trying to fight them off. So the last part of the complete blood count is platelets, and their main function is to clot the blood. Therefore, if you have too few, you'll often have issues such as easy bruising or bleeding that just won't stop. And this can actually get quite serious. So you can have like a nosebleed for several hours if you have very low platelets, and you can actually lose a lot of blood that way. So if they're too low, there are a variety of different causes, but typically it does have something to do with the bone marrow because the bone marrow is responsible for producing red blood cells, white blood cells, and platelets. So if they're not working properly, or there's a genetic condition or a malignancy, then that can cause them to be too low. And then certain medications that are more immunosuppressive or chemotherapy or radiation can also lower numbers. It's less common for them to be too high, but in certain cases, it can be related to processes that would trigger more platelets to be made, such as an acute episode of bleeding or surgery. Certain cancers or infections can also cause increases as well, and certain autoimmune disorders or anemias as well can cause the bone marrow to kind of overcompensate. Now we'll move on to electrolytes. So we're talking about sodium, potassium, chloride, and bicarbonate. And sometimes there might be a few more that are added on to the test, but these are typically the ones we're looking at. So these are all very important for fluid balance and dictating how much fluid remains in the blood versus going into the tissues. So if they are extremely high or extremely low, this can be a life-threatening emergency, especially when it comes to potassium, like we mentioned before. So I won't go into chloride and bicarbonate on their own, as they're usually never ordered individually. So typically you'd order all of these together. And they're usually interpreted alongside sodium and potassium. But they are very important for keeping the pH of the blood from getting too acidic or too alkaline, especially when it comes to bicarbonate. It acts as a buffer in the blood. So sodium is a very important electrolyte when it comes to fluid balance, like I said, as well as for the nervous system, and it's a really big determinant for blood pressure. And so the kidneys are primarily responsible for processing sodium and dictating how much is excreted versus recycled back into the body. And so this, the normal range is between 135 to 145 milliliter equivalents per liter. And so essentially this implies that it's not an absolute value, but instead can be also influenced by the actual amount of sodium in the blood, but also the amount of fluid that is present. So when sodium is too low, it's called Typo Neutrinia. And so there are a variety of causes, such as certain medications. So for example, a lot of blood pressure medications such as diuretics will purposefully cause sodium to be excreted at the kidney in order to reduce the amount of water, because essentially if there's a lot of sodium, water likes to follow with it. So if you get rid of that sodium, you'll end up getting rid of a lot of water, and that'll decrease your blood pressure. So similarly, conditions that cause fluid accumulation within the body, such as heart failure, kidney disease, or liver disease, can lead to dilution within the blood. And so this makes it look like the concentration is actually lower than it is. Things like consistent vomiting or diarrhea can also lead to a loss of sodium as well as fluid. And interestingly enough, a common mistake that many people at athletic events make is to overhydrate without replacing electrolytes. So people will drink a lot of water, thinking that they need to rehydrate themselves without actually replacing the sodium that they're losing through sweat. And this essentially just leads to the blood being more and more diluted, and people can actually get quite confused and quite sick during these races because of that. So if that's ever something that you enjoy doing, don't forget to drink your Gatorade on those days. When sodium is too high, it's called hypernatremia, and often it can be caused by severe dehydration or inability to access water. So severe diarrhea and vomiting can also lead to hypernatremia as long as the proportion of water lost is greater than the amount of sodium. So if you didn't know, the skin, one of the primary functions of the skin is to prevent diffusion of water. So severe burns that disrupt that skin barrier can also lead to really rapid water loss, as well as kidney issues that increase resorption of sodium. There's a condition called diabetes insipidus as well. You may or may not have heard of it. So basically the body doesn't produce enough antidiuretic hormone, and that hormone is responsible for concentrating the urine. So essentially you're just losing all of this water in your urine without actually retaining any of it. And this can cause people to become quite hypernatremic. And so we'll talk about potassium. It's a very important electrolyte when it comes to fluid balance as well, and the nervous system and also the cardiac system. And its normal range is between 3.5 to 5. And so when potassium is too low, it's called hypokalemia. So similar to sodium, this can be caused by severe vomiting or diarrhea or medications that cause excretion of potassium in the kidneys. So again, certain blood pressure medications do cause that. Hyperaldosteronism, so aldosterone is also a hormone that acts on the kidneys, and it's responsible for reabsorbing sodium from the kidneys. And it works on a certain transporter that essentially trades sodium for potassium. So if that hormone is severely elevated, that can lead to big loss of potassium. So hypokalemia is very important to treat because it can lead to abnormal heart rhythms, but typically it's not as severe as hyperkalemia, but it is also very important to treat. So when potassium is too high, it's called hyperkalemia, and moderate to severe hyperkalemia is a severe medical emergency. So abnormally high levels of potassium can either start to overwhelm the kidneys, and lead to kidney failure or can induce cardiac arrest. You may or may not be familiar that in the United States, because they still euthanize prisoners there on occasion, what they will do is give a very high dose of potassium, and that is what will cause people to die, essentially. So it is a very potent, but can get quite dangerous. And that's typically why we don't recommend potassium supplements as well. So most often it is caused by kidney disorders that prevent the excretion of potassium. And like I mentioned, certain medications can also act in the same way or cause large releases of potassium from the cells. So definitely something we want to watch out for. And I'll also talk about calcium. So it's technically not an electrolyte, but it is an ion. So I figured it would be best to talk about it here. And as we all know, it's very important for bone health, but it is also very important for cardiac health as well. And so when the calcium is too low, it's called hypocalcemia. And this can lead to weakened bones that are more prone to fracture and can also make muscles more prone to twitching and cramping. That's why you might see some people chewing Tums during athletic events. In severe cases, it can also lead to seizures and arrhythmias. So it's also something that we want to watch out for. And so there are multiple different causes of hypocalcemia, and typically this test will be ordered as part of a complete metabolic panel, or if you're demonstrating symptoms of hypocalcemia. And that can involve twitching, like I mentioned, or other symptoms as well. So certain conditions that can cause hypocalcemia include liver disease, malnutrition, or inadequate intake of calcium. And in Canada, one of the big reasons is vitamin D deficiency. So even if you're consuming sufficient amounts of calcium, if you're vitamin D deficient, the body has no way of getting that calcium and absorbing it. And so that is one of the big causes of calcium deficiency in Canada. Renal failure and certain medications as well, even medications that can be used to treat osteoporosis, such as bisphosphonates, can actually lower calcium because they're using that calcium to go towards the bones. So that lowers the levels in the blood. On the other hand, when calcium is too high, it's called hypercalcemia. And we are a bit more worried about if we do see hypercalcemia because it can be a sign of cancer. And this can also lead to some more common but distressing conditions such as kidney stones or inflammation of the pancreas or pancreatitis because of too much calcium in the blood. It can also be a sign of hyperparathyroidism. So there are 4 parathyroid glands, and they're kind of embedded within the actual thyroid gland, which is just in your neck here. If they're over-secreting parathyroid hormone, this leads to an increased resorption of calcium. So that's definitely something we would investigate a little bit further. And then certain medications as well, such as thiazide diuretics, consuming too much calcium supplementation can also cause hypercalcemia. So typically, if you want to get calcium from your diet, that's typically the way we want to go, rather than calcium supplementation, unless you're really not getting any from your diet. So we'll talk about lipids now. So a lipid panel is typically part of regular screening for cardiovascular disease. And we would do this about once every 5 years if you're a man over the age of 40 or a woman over the age of 50, unless you have additional risk factors or have demonstrated some signs of cardiovascular disease. And then that's when we monitor it a little bit more frequently. And so it can also be used to monitor treatment efficacy for medications that are meant to lower lipids, such as statins. So if we're not seeing any differences after you begin a medication, then we might want to change the medication or increase the dose and things like that. So this will typically include looking at triglycerides, total cholesterol, LDL, and HDL cholesterol. So in terms of triglycerides, so we're measuring the amount of triglycerides in your blood, and this is one of the larger lipid molecules that circulate around. And when you consume a meal, especially if it's high in fat, triglycerides can be released into your bloodstream in order to be stored for future energy needs. And we typically only worry about it if it's too high. There's really no such thing as it being too low. So if it's too high, we're worried about the risk for heart attack and stroke, as well as inflammation of the pancreas. And some ways that you may be able to lower these involve through exercise or diet changes, as well as weight loss and certain medications such as statins, like I mentioned. And as well for cholesterol, so many studies have shown the link between cholesterol levels and cardiovascular disease. So that's why it's used in terms of calculating your disease risk alongside family history, your personal medical history, and things like that. So generally, LDL cholesterol is considered to be the bad type of cholesterol, as it's known to deposit itself within the plaques of the arteries. And over time, these plaques can grow through a process known as atherosclerosis, and this can cause narrowing of the arteries. And that obviously increases the risk for serious events such as heart attacks and strokes, especially if these plaques start to break off and stuff from the inside starts to go into the bloodstream. This can eventually travel to the heart and the brain and the lungs, and that's obviously not something that we want to happen. So as a result of that, you want to have low levels of LDL. On the other hand, HDL cholesterol is considered to be a good cholesterol, as it can help to reduce and prevent this process. So as a result of that, you want to have higher levels of HDL in your blood. And like I said, the information from these tests will help determine your cardiovascular disease risk and dictate whether any prevention or treatment is needed. So in terms of glucose, so a big predictor of heart disease is diabetes, and catching diabetes mellitus specifically early is essential for preventing serious consequences down the road. And therefore your physician may order one or more of these tests as part of regular screening as well. And especially because a lot of people are asymptomatic at the beginning for type 2 diabetes, it's very important to detect it early. So as a reminder, diabetes mellitus happens due to the body's inability to either make insulin, as with type 1 diabetes, or due to insulin insensitivity or resistance, as in type 2. And insulin is made by the pancreas, hence the giant pancreas on the screen. But since typically type 1 diabetes will be diagnosed in childhood, we're really screening for type 2 diabetes. And if you'd like to know more about diabetes, Nicole will be giving that talk in about 2 weeks' time. So we highly encourage everyone to go and see that one. So the two most common tests that are used are called fasting plasma glucose and hemoglobin A1c. And another test called random plasma glucose can also be used. But in terms of diagnosing diabetes, these are typically the two that we're going to use because glucose levels naturally fluctuate throughout the day and are very meal dependent. As you can see here, depending on where you measure it, it's a little bit more finicky. So that's typically in terms of why we would use the other two in terms of the actual diagnosis. So fasting plasma glucose measures the concentration of blood glucose at least 8 hours after a meal. And so it gives you a snapshot in time of what the baseline levels of glucose concentration are in your blood at that specific time. So Diabetes Canada typically recommends this to be done every 3 years if you're over the age of 40, or every 6 to 12 months if you have additional risk factors such as family history, if you have like cardiac disease or kidney disease, or if you're of a certain ethnicity as well, or if you're in the more at-risk or pre-diabetic categories as well. So we'd love for everyone to be in this normal category under 5.6. But if you're starting to be in the at-risk category of 5.6 to 6, then we will typically monitor a little bit more closely. In the pre-diabetes category, definitely lifestyle interventions will be mentioned, such as more exercise and watching certain foods in your diet. You may also receive treatment such as metformin to reduce your glucose levels. And then if you're over the 7 range, then that's typically when diabetes will be diagnosed if you have that result on multiple tests. So the other test is called Hemoglobin A1c, and this gives a better insight into how blood sugar has been over the past 3 months. So as you can probably imagine, if you have really great blood sugar control in the week leading up to your fasting plasma glucose, your results may be quite good, even if you didn't do so well in the 3 months prior. So this is a really great test, especially with people with active diabetes, and gives a better sense of how the blood sugar has been controlled over that longer period of time. So like I said, it's typically used in conjunction with fasting plasma glucose in order to screen or monitor for diabetes. And it is also recommended to do every 3 years or more frequently if you're at risk. So this is the last category, and then we're going to have a brief intermission. So we'll talk about tests that monitor for kidney function. So as most of you know, creatinine and glomerular filtration rate are great tests that we use to monitor for kidney function. And you may have also heard of a test called urea or blood urea nitrogen, so that can be used as well. We've just been studying the kidney for the past 2 weeks in our medical school curriculum, so I've learned that the kidneys are very, very complex and very, very important to bodily functions. So if they are over under excreting certain substances, this can definitely have very major consequences for other organs in the body. As well, it's very important to monitor for kidney function in the context of medications, because a lot of them are excreted by the kidneys and through the urine. And so any decrease in function in the kidneys can alter how a medication is metabolized or cleared in the body, and may require dose adjustments as a result. So blood urea nitrogen is one way to assess kidney function, and it'll typically be ordered alongside the other two. And it's a measure of the urea nitrogen in your blood. So the way urea nitrogen is created is because the protein is broken down by the liver, and this causes the release of nitrogen. This nitrogen then combines with other molecules to become urea, and then this travels in the bloodstream to the kidneys to be excreted via the urine. So there's another blood test, like I mentioned, that's called total urea or just urea. It is very similar to BUN or blood urea nitrogen. So often you would never do both of them, and the numbers are slightly different, but they're essentially looking at the same thing, which is the body's ability to excrete urea. So an elevated level of urea nitrogen would indicate that the kidneys aren't able to excrete as much as they should. And this can be due to kidney disease. It can also be due to more benign causes such as dehydration. Since this is a concentration, again, if there's less fluid, then the concentration will automatically increase. A high protein diet can also lead to more nitrogen urea being produced. And it can also increase with conditions such as heart failure or a recent heart attack, as well as bleeding or certain medications as well. So it's less common to have low BUN levels, but they might suggest an underlying liver disease. So basically, if the liver is not functioning properly, it can't process that protein, and therefore you're going to have less urea at the end of it. Similarly, a low protein diet or overhydration would also lead to lower BUN levels. So creatinine is another test that can be used to help determine kidney function, and it can either be done as a blood test or can also be measured in the urine. And typically it will be measured in both in order to kind of see whether the kidney is actually excreting it as it should. And in certain cases, you may even require a 24-hour urine collection known as a creatinine clearance, especially if there's a question about inflammation within the kidneys. So creatinine is essentially what's going to be used to estimate glomerular filtration rate, because we can't actually measure what the rate is. It goes into this complicated equation that accounts for things like age and sex and race in certain cases, and then that will tell us what your glomerular filtration rate is. So creatinine is a waste product that comes from skeletal muscle. And so, like I said, you can't really use it on its own because it can be highly variable from person to person. especially when it comes to age and sex and muscle mass. So for example, a supramuscular person may have a normally higher level of creatinine because they have a very high level of muscle mass, whereas someone with a low muscle mass may have a very low creatinine as a result. So that's where that clinical context comes in. We would expect a higher creatinine level with that very muscular person, but if that same number came with the low muscular person, then that would be abnormal for them. So high levels of creatinine are frequently very important for kidney disease or anything that may cause an increase in the production of creatinine or a reduction in the kidney's ability to filter creatinine from the blood. So things like autoimmune causes, bacterial infections of the kidneys, heart failure, as well as complications of diabetes can all increase creatinine. And there are also circumstances where creatinine may be high, but not necessarily as a result of disease. So in certain cases, pregnancy can elevate the level of creatinine. Intense exercise where you're breaking down some muscle can also increase the creatinine in the blood. A high red meat diet and certain medications as well. So in terms of glomerular filtration rate, or I'll call it GFR, is an estimate. So that's where that creatinine is going to be used to help estimate this. And in the simplest of terms, I'll try to explain kind of how the kidneys work. So this entire big thing right here is called the nephron. And so basically you have thousands of these little nephrons within the kidneys, and they're all responsible for clearing the blood of different substances. So blood essentially enters in through this arteriole here, comes into this big bulb called the glomerulus, and based on the amount of pressure that's coming in, or depending on different states within the body, certain substances will be pushed into Bowman's capsule here, and that will lead to them potentially being excreted if the body doesn't need them. If the body needs them, they may be reabsorbed back into the blood. So essentially, everything that we don't need will go into the urine, and everything that we do need will go back into the blood. And so over time, eventually, as we age, this can start to decrease naturally. But if it does start to decrease a little bit faster than we would expect, that might be significant for kidney disease. And so, or if we also get a buildup of proteins within the blood, then that can also indicate that it's not working as it should. And that's where dialysis may come in. So in the end stages of kidney disease, this process really isn't working. Nothing's really being filtered. And so then you need a dialysis machine to do that for you. Certain medications can also alter kidney function. And so GFR can also be used to monitor whether medications may need to be reduced or changed if they affect kidney function. So I know that was a lot, so we'll take a 10-minute break right now. If there are any questions, feel free to put them in the chat, and I'll try to answer them when we come back from our intermission, and then we'll get into some more specific tests that we may order. So hope you all enjoyed your break. I did get a few questions in the chat that I can quickly address. So I had a question about like how the hemoglobin A1c actually works and how we actually know it's working for the past 3 months. So basically, hemoglobin travels on the red blood cells within the blood, and based on the actual levels of glucose within the blood, glucose can attach onto hemoglobin. So the higher levels, the higher the level of glucose attached to hemoglobin, the more glucose we know is in the blood. So it's kind of a direct relationship, and it just accumulates over time. I hope that kind of answers the question there. And then another question about vitamin D. So whether sunlight is enough or a supplement is also needed to increase calcium absorption. So especially in older age, most physicians will recommend a vitamin D supplement, especially since we live in Canada. just because the amount of vitamin or the amount of sunlight exposure we get isn't super high, especially in the winter time, unless you're going down south, for example. So yeah, a lot of times, most people won't get to the level that they're actually deficient, but most people won't be meeting their requirements either. So it is all good to ask your doctor about that and whether you need a vitamin D supplement or not. You can also get it through certain foods, such as fatty fish, but a lot of people do choose to do supplementation because it's a little bit easier. Hopefully that answers the question. Okay, so Dr. Garris sends her regards. Unfortunately, there seemed to have been a power outage on her block. A truck hit a line or something like that. So she did want to say hi to everyone, and she will be at the next one. Okay, so if there's no other questions, again, feel free to put them in the chat and I'll try and answer them at the end. So we'll move on to the more specific one. So this part of the talk will be a little bit shorter, so hopefully we can be done by 2:30. And I'll go over the more specific tests for the heart, the liver, certain hormones as well that are more common, as well as blood clotting. So in terms of the heart, these are typically going to be ordered in the acute setting. So things such as troponin and D-dimer, and they'll be looking for heart damage or clotting activity, essentially. And this is just your friendly reminder that these are the more common signs of heart attack. And in men, they are typically the more typical ones we think of, such as chest pain, discomfort, radiation to the arms, back, neck, and jaw, as well as the shortness of breath. But in women, sometimes these don't actually show up and they can be more around the realms of fatigue or nausea, vomiting, or indigestion type feelings. So please do always get checked out if you feel like something is wrong, because this is not something you want to miss. Let's talk about troponin first. So this test basically measures the amount of troponin in the blood. And so troponin is a type of protein that's found in cardiac or heart muscle. And it's unusual for it to be present in the blood normally. So its presence at a certain level would indicate that there was some level of damage to the heart. And the reason that we can make that correlation is because it is a protein within the muscle. If the muscle starts to die off due to like a heart attack and lack of oxygen, it starts to break down, and then that's why troponin will be released into the blood, and then we can detect it. So it is typically thought of in the context of heart attack. And basically, like I said, if you mention the words chest pain in the ER, you will get a troponin done. But it can also be used as it might also be an indicator of heart failure or angina, which is a temporary spasm of the vessels of the heart that can limit blood flow. Usually it's reversible, but can eventually lead to more serious cardiac disease. It might also be an indicator of a blood clot in the lungs, which is called a pulmonary embolism, which can also lead to heart damage as well. And so, like I said, a healthcare provider will frequently order this test in order to rule out a cardiac event. That's typically why it'll be ordered in the ER. And it'll typically be measured alongside an electrocardiogram or an ECG. And so if you've ever had a troponin ordered in the ER, you know that this test, unfortunately, will take a long time because troponin levels often take a few hours to rise. So you'll know that they'll take your blood initially, look at it for troponin. Even if it's negative, they'll typically hold you in hospital for at least 6 more hours to repeat that test again. So that's not at all to try and discourage you from going to the hospital. It's always better to be safe, but just know that that's why they hold you in the hospital for so long. And then I'll talk about D-dimer. So this test is measuring the levels of D-dimer in the blood, and it's also usually ordered in the acute setting and the setting of potential blood clots. So D-dimer is considered an indicator of clotting activity, and it's produced when a clot essentially starts to dissolve. So it's one of those end products. So there's a couple different causes that are pretty important to diagnose and we don't want to miss, such as a deep vein thrombosis or DVT, which is a blood clot in the veins. Typically that occurs in the legs. A pulmonary embolism as well is often a complication of a DVT and is a blood clot in the lungs. So basically a part of that clot in the leg can break off and make its way up and potentially lodge itself in the lungs or in the heart or in the brain as well. So it can also be ordered in the setting of an ischemic stroke. And so this picture is basically just showing that the clot can essentially start to lodge itself, and then bits and pieces of it can start to travel to other places and wreak havoc elsewhere. I included this picture to show you just how big these clots can actually become. So you might not be super familiar with what you're looking at, but basically these black things are the lungs, and this thing in the middle is the heart, and this big white trunky vessel type thing is the pulmonary trunk. So this is the blood that's going to the lungs. And if you see this big, giant, dark piece right here, that's just in the middle there, that's a blood clot or a pulmonary embolism. So as you can see, these can get quite serious and can block off a lot of blood flow. And that's why it's very important to catch these, especially earlier on, because they can lead to death, unfortunately. So we'll talk about the liver now and some enzymes and some proteins that are produced by the liver, such as albumin or bilirubin or ferritin, as well as the liver enzymes. So albumin is a protein that's produced by the liver, so that's why it's in this category. And it has many important functions, including transporting various vitamins or minerals. So it's a really big transporter of calcium, for example, or different enzymes. And it's also very important for retaining fluid within the blood. So low levels would indicate hypoalbuminemia. And most commonly, this will have something to do with liver function, and usually happens in more of a chronic setting, such as with cirrhosis or liver cancer, hepatocellular carcinoma. It can also be due to kidney issues where protein leaks out into the urine. So you may remember that big glomerular thing. Basically, you shouldn't have protein going through there because albumin is quite a big protein. So if you do start to see albumin in the urine, then you know that something is going wrong with the kidneys. It can also be low levels of albumin can also be present due to systemic inflammation, especially if that affects the kidneys, or malnutrition if you're not getting enough protein, or GI issues as well. We don't typically see too high levels of albumin, but usually these would be due to more of the dehydration or fluid loss, such as with severe diarrhea or vomiting. So like I said, you can also measure albumin in the urine, and it's a pretty common thing to measure it. And this can help determine the cause of the high or low albumin. So for example, if the albumin is low in the urine, but high in the body, then we know it's probably a liver issue. Whereas if albumin is in the urine, then we know it's probably more of a kidney issue. Yeah, and then you can order albumin relative to other things such as creatinine. So that's very important with diabetes, as albumin can start to accumulate in the urine due to diabetes. You can also compare it due to overall protein, and this can help to distinguish the type of kidney disease that might be going on. Bilirubin is also an important part of a liver panel, and it's one of the end products of red blood cell breakdown. And so that's a function of the liver, is to break down red blood cells. So if bilirubin starts to collect in the blood, this can lead to the classic sign of liver disease, which is jaundice or yellowing of the eyes and skin in more severe cases. So basically, this is what's going to turn you yellow. So any liver diseases such as hepatitis or blood disorders that increase red blood cell breakdown will increase the levels of bilirubin. As well, if you start to have blockage of the bile duct, this can also start to increase bilirubin levels. And the bile duct is just one of the passages that comes out of the liver. I wanted to mention liver enzymes as they are typically ordered as part just to monitor liver function. But I won't get into each one of these specifically, as it's very important to interpret all of them as a whole, because if one of them is elevated relative to the other, then that can kind of help distinguish the cause. Whereas if all of them are elevated, then that might point more to a liver cause. And especially because many of these enzymes are also found in multiple places in the body. So for example, alkaline phosphatase or ALP is also a very big indicator of bone metabolism. So if ALP is elevated and only ALP is elevated, then we might think of this due to a bone cause rather than a liver cause. But again, if they were all elevated, this might point to more of a liver dysfunctional process going on. So I'll talk, and ferritin is a protein that's also found in the liver and produced by the liver. And it's responsible for binding iron. So this one's also very important in the setting of anemia. And because it's responsible for binding iron, iron is also a very important part of hemoglobin and therefore red blood cell formation. So if you have low levels of ferritin, then that might be diagnostic of iron deficiency anemia, for example. And that's a big common cause of anemia, but also a very correctable cause as well. So basically, if there isn't sufficient levels of iron in the blood or levels of ferritin, new red blood cells won't be formed because they don't have the building blocks that they need. And this can lead to lower red blood cell levels. So like I mentioned, if they're too low, this could be a cause of anemia due to bleeding or iron deficiency. And this is just a schematic of what hemoglobin looks like. And you have 4 of these on every red blood cell. And in the middle of that, you have iron. So it's a very important building block for red blood cell formation. If ferritin levels are too high, this could be indicative of things that affect the liver, such as alcohol abuse or infection or liver disease as well. So I only have a few more slides left here, but we'll talk about the blood's clotting ability or coagulation. So there's 2 main tests that we will look at for these. One's called the prothrombin time. You may have heard about INR. This is very similar to it, as well as the partial thromboplastin time or PTT. So the prothrombin time, also called PT or sometimes INR in very specific situations, measures the extrinsic and common pathway of clotting. And I'll show you what that looks like on the next slide. But essentially, in order for the blood to clot, there are several different steps and factors that have to happen in order to reach the final product, which is the clot. If there are any deficiencies along those pathways, this will cause the blood to take longer to clot, which can pose an issue when it comes to bleeding. Or if it's clotting too much, then this can also pose an issue in terms of risks for blood clots and things like that. So the PT test will typically only be ordered in the setting of excessive bleeding, in which a bleeding disorder may be suspected. So if any of you have taken warfarin, also known as Coumadin, it's a blood thinner and prevents clots from forming. And you'll know that you have to monitor your INR very closely to ensure that you're not under or over anticoagulated. So INR is essentially the exact same thing as PT time, except it's been internationally standardized and is only specific to warfarin. So that way you can go to any lab anywhere and know that the measurements will be standardized to warfarin specifically. So reasons that PT time might be too high, aka the blood is taking longer to clot, which we don't want unless you're on warfarin, then this could indicate a bleeding disorder or a vitamin K deficiency, since vitamin K is very important for a lot of the different factors within the clotting cascade. It may also indicate an issue with the liver, because the liver is responsible for making a lot of these clotting factors. And so things like cirrhosis can lead to a prolonged PT time. And like I said, because we want the blood to not clot as well, if you're on warfarin, then we would expect the PT time or INR to be higher. So it's not alarming if it's higher, unless it's 2, unless you can overdo it as well. So we want it in a very specific range. And so this is the clotting cascade that I was talking about. So these 2 tests are slightly different. So the PT time, like I said, was measuring the extrinsic pathway and the common pathway, whereas the partial thromboplastin time, or PTT, is measuring this part of the pathway. And so the benefit of doing both of these tests is that you can kind of figure out where the clotting issue might be. So if you have a prolonged PTT time, but your PT time is normal, then you know that the issue lies in the intrinsic pathway and vice versa. Whereas if both of them are longer, then you know the issue is with the common pathway. So again, this test may be ordered in the setting of a suspicion of a bleeding disorder, such as hemophilia or von Willebrand disease, although you wouldn't know that until you did these tests. And without these tests, it would be hard to distinguish the type of bleeding disorder that's present. Again, if you have vitamin K deficiency, this will also lead to prolonged PTT times. And in lupus, there are certain antibodies that can be formed that disrupt these pathways as well and cause it to be prolonged as well. So we'll finish off by talking about thyroid hormones as well as prostate hormones. Obviously, there's way more hormones that exist, but I thought these 2 would be most relevant for this group and most commonly screened. So as with many hormones in the body, there's multiple areas that can feed back on each other to reach the desired range. So the hypothalamus lies in the brain, and it's considered the control center of hormones, basically, and releases what's called, in the setting of the thyroid system, it releases thyrotropin releasing hormone. This goes on to act on the anterior pituitary gland, which is also right underneath the brain, and that releases thyroid stimulating hormone, or TSH. TSH then goes to act on the thyroid, which then produces all these thyroid hormones, which then go on to act on the body in different ways. If you have any issues along that pathway, then this can start to throw everything out of balance, and then that's when you start to have hormone dysfunctions. Yes, hopefully that makes a bit of sense. And so when we're testing the thyroid, typically we'll start with testing the thyroid stimulating hormone. So that hormone that's linking the anterior pituitary gland to the actual thyroid itself. If it comes back abnormal, or you have severe symptoms, even in the setting that it might be normal, you'll likely measure the actual thyroid hormone levels, so the T3 and T4 themselves. So to try and explain things and try to keep things a little bit simple, if your TSH, or thyroid stimulating hormone, is low, this would indicate that you have hyperthyroidism, aka there are high levels of T3 and T4, because the brain is able to sense that these levels are too high and then tells the brain to not produce as much thyroid stimulating hormone. So it's basically feeding back on itself. And then as a result of that, you'll have a low TSH. A common cause of this is Graves' disease, which is an autoimmune disease. And basically a bunch of antibodies are formed against the thyroid, and this overstimulates the thyroid, and you get very elevated levels of T3 and T4. Sometimes you can also get nodules within the thyroid that overproduce these hormones. And in certain cases, sometimes you can have a viral illness, or in pregnancy can cause thyroid inflammation or thyroiditis, and this can also lead to high levels. On the other hand, if TSH is high, this would indicate that you have hypothyroidism. So similarly, as hyperthyroidism, the brain can tell that the levels of thyroid hormone in the body are too low and would want to increase the amount of thyroid hormones being produced. Therefore, it would increase the level of TSH as a result of that, in order to attempt to try and produce more thyroid hormone. So one of the most common causes of this is Hashimoto's disease, which is an autoimmune condition that leads to hypothyroidism and is one of the most common causes in older age. Interestingly enough, a lot of the treatment options for hyperthyroidism can also lead to hypothyroidism, such as removing the thyroid or radiation to the thyroid or certain medications as well. As much as I would love it to be that simple, it's not always the case. So sometimes TSH can be what we call inappropriately normal, meaning that even though the level comes back normal, it shouldn't be that way. Especially when it comes to hypothyroidism, these changes often take many months to take effect. And so your thyroid levels might be going down, but your TSH might still be normal. So that's typically why you might order a T3, T4 in the clinical setting or suspicion of hypothyroidism. And I'll finish off, this is our last big slide here, talking about prostate-specific antigen, as it's a common test done in older men to monitor for prostate cancer. So there's been a lot of controversy over prostate cancer in recent years and whether it's actually valuable to screen for it. And that's because the test we use, which is PSA, can be elevated in the case of prostate cancer, but can also be completely benign, even if it's elevated. And so as with many tests, if the result comes back abnormal, this typically will trigger many further investigations, which in the setting of the prostate can actually be quite invasive and have risks of things like infection and may have a negative impact on quality of life. So for example, 20 years ago, we might have just removed the prostate, and that can obviously have a pretty impactful effect on quality of life. And as well, prostate cancer is also typically quite mild. That's not always the case. But for most people, even if you do have prostate cancer, it's unlikely to be very aggressive or affect your life very much, or even need any treatment. So again, that's not always the case, but it remains to be kind of debated whether PSA is the best way to screen for this and what the best way of detecting the more aggressive forms of prostate cancer are. Okay, so that brings me to the end of the talk. So I just wanted to suggest some helpful resources if you wanted to know a little bit more. So as always, your healthcare provider or pharmacist can actually be very helpful, especially the pharmacist is very helpful in the setting of medication questions. And again, like I said, a lot of these tests can be ordered for a multitude of reasons. So I may not have mentioned the reasons why you might be having a specific test done. So they're always the best place to start. Looking up things on HealthLink BC, they have a really great website. A lot of the information I got was actually from HealthLink BC in terms of these tests, so they explain things really well, as well as the hotline or 811. Because of the vaccine passport, many of you may be familiar with Health Gateway, but that can also show you what medications you're taking or have been ordered, as well as certain tests. I don't know if lab results are on there yet, but I think that's coming up soon. If you go to Life Labs, all of those results are available online at My Care Compass. So you can always look there if you want to see what things have done over time. And then if you like to look at certain websites and like things a bit more technical, Medscape is a great place to start and has more technical terminology. Things like WebMD or Mayo Clinic or Cleveland Clinic have things explained a little bit more simply, but again, just be careful with those, as cancer always seems to be one of the reasons for everything on that site, so just be mindful of that. And this is the same as before. These are our future talks, and we have 2 more in the next 2 weeks. So we'd love to see all of you at some of them or all of them if you're able to. And like I said, all of these presentations are recorded and will be posted on Dr. Vier's website, which I've included in the email that you would have got before. So check back there. They should be uploaded fairly soon after our talks as well. Thank you so much for your attention. And if you have any questions, that would be great. Or if you'd like to head out, then that's totally fine as well. So I see one question in the chat there. So what is a CRP test used for? Oh yeah, I didn't mention that one. So CRP is called C-reactive protein, and it's typically ordered in the setting of inflammation. So if there's suspicion of an autoimmune disease, I think as well in the setting of cardiac medications or cardiac conditions, there's a lot of different conditions you can order that one for. But generally that is, along with ESR, can also be ordered in the setting of inflammation. And that's what it will be used for. Any other, hopefully that answers your question, Brenda. Any other questions or any comments? I'm always open to feedback. Okay, it doesn't look like there's any other questions coming in. Thanks so much for the positive comments, and thanks for taking time out of your Sunday afternoon. We really appreciate it. And please feel free to email us if you have any other questions or any feedback or comments as well. What about Lip A? I am not too sure, Grace. That is a good question. Nicole or Drew, do you guys know about Lip A? I would assume that's lipase. Is that lipoprotein A? Oh, can't say that I know, Grace. I'm sorry. If you'd like to, oh, it's an indicator of possible heart disease. There you go. Yeah, if you'd like to follow up with that and email us, feel free to do so, Grace. We can try and see what we can come up with. We do a lot of cardiac talk. We're taught a lot about cardiac function next semester, unfortunately. So maybe ask us again later. Any other questions, comments? Okay. Well, thanks so much again for taking time out of your Sunday afternoon. We really appreciate it. And we hope to see you same time next week at Drew's talk on genetic testing. Thank you so much.